Good morning, everyone. I am Dr. Vijeta, and today I am going to discuss test of ovulation, which is very important for the evaluation of infertile couple as it contributes to 15% of all infertile couples and up to 40% of infertility in women. So, the most common causes of ovulatory dysfunction include polycystic ovarian disease, obesity, perimenopause, weight gain or weight loss, excessive exercise, thyroid function, and hyperprolactinemia. Let's discuss the various tests which are used for the ovulatory function. So, the test which is used for assessment of ovulatory function are menstrual history, second, luteal progesterone, third, ovulation predictor kits, transvaginal ultrasound, basal body temperature, endometrial biopsy, and changes in the cervical mucus. Let's first discuss the very important, that is menstrual. So, menstrual history is a very important part of infertility evaluation as if the menstrual history, that is menstrual cycle, is regular and predictable, occurring at an interval of 21 to 35 days with consistent flow characteristics and accompanied by a consistent pattern of monominal symptoms, then the most likely the patient is ovulating. But sporadic anovulatory cycle can occur in a regularly menstruating woman, but the incidence is rare and it is about 1 to 14%. If the patient has normal menstrual cycle and she is not Hirschhorn, then the chances that she has ovulatory cycle is as high as 99.5%. If the patient is menstrual cycle are normal and but she has Hirschhornism, then the chances that she is ovulatory reduces to 60%. So in that patient, there is a role of luteal progesterone level, and this helps us to confirm whether the patient is ovulating or not. We'll discuss the luteal progesterone level in subsequent slides. In the previous slide, we have discussed that if the menstrual cycle are normal, regular and predictable, it means that the patient is ovulatory in most of the condition. But if the patient cycles are irregular, that is oligomenorrhea or amenorrhea, then we don't need any further test for ovulatory status as evidenced by the history only that the patient is anovulatory. But in this condition, we need to find the cause of anovulation. So, for example, if the patient has a cycle of 45 days, then we know that the patient is anovulatory. And we didn't want to do any ovulation test for the patient to prove that the cycles are anovulatory. In this patient, we just wanted what is the type of anovulation or what is the cause of anovulation. As we all know, there are three types of anovulation: WHO type 1, type 2, and type 3. In this patient with oligomenorrhea and amenorrhea, we wanted to know whether the patient is type 1, type 2, or type 3, as the treatment will depend on these factors. So, coming to the next slide, if the patient has irregular cycle, what all tests we need to do to know the cause of anovulation? The first is thyroid stimulation hormone, as it will affect the LH and FSH and will cause the cycle irregularity and ovulation. So first we have to correct this thyroid stimulation hormone if it is deranged. The second is prolactin. In normal patient that has a regular cycle, 28 to 35 days cycle, we don't need to do prolactin. But if the patient has a complaint of galactorrhea, or if the patient has oligomenorrhea or amenorrhea, it is recommended to do serum prolactin to know whether this can cause anovulation or not. After ruling out thyroid and estradiol. So if the FSH is high and estradiol is low, this means that the ovarian insufficiency is there and they are the candidate for oocyte donation. And if the FSH is also low and estradiol is also low, this means they are hypothalamic amenorrhea and they'll require exogenous gonadotropin for stimulation of ovulation induction. If both the hormones are normal, that is FSH and estradiol, then this is the most common cause of anovulation, that is WHO type 2 anovulation, which is PCOS. So in these patients, we need to do the test for PCOS, and if the patient has a clinical signs of androgen axis, so we need to do an additional test for 21 hydroxylase deficiency to identify non-classical adrenal hyperplasia. So as far as we have discussed that if the menstrual cycle are normal, then it is most likely the patient is ovulatory. And we don't need to prove that. But if the patient has irregular cycle, that is oligomenorrhea or amenorrhea, in this case also, we don't need to prove the test for ovulation. We just wanted to know the type of anovulation or the cause of anovulation. Let's discuss further this diagram. If the patient is presented with irregular cycle, we need to first rule out hyperprolactinemia and thyroid. After that, we have to distinguish between WHO 1, 2, and 3 ovulation disorder. So, as we have discussed in both LH, FSH, and E2 are low, it is type 1 anovulation, and in this patient, we require gonadotropin for ovulation induction or stimulation. And if the FSH and E2 are normal, that is the most common cause of anovulation, that is PCOS. We need to do the test for PCOS and also 21 hydroxylase deficiency in case of patient has a features of excessive hairs. If the patient has high FSH and low E2, that means ovary has failed and we require donor oocyte in that condition. So it is very important to know the type of anovulation to know the further management. So after discussing the menstrual cycle, we let's move